Welcome aboard the SS Hyperemesis. Looks like we've got some choppy waters ahead, so I hope you brought your barf bags, because this one isn't going to be pretty. One of the most notorious side effects of pregnancy is morning sickness. While this is a bit of a misnomer, as nausea and vomiting can strike at any time of day, you'd be hard-pressed to find someone who doesn't know that pregnancy can equal puking. In fact, more than 50% of pregnant women will experience some form of nausea and vomiting. That's over half. Unfortunately, barfing with a bun in the oven can take on a number of forms. Nausea and vomiting in pregnancy doesn't have just one clinical presentation. In fact, it's a spectrum of disease. On the milder end of the spectrum, you have the occasional bout of morning sickness that's bothersome but doesn't require any intervention. On the other end, you have a serious illness called hyperemesis gravidarum, which is uncontrollable, unrelenting nausea and vomiting that leads to malnutrition and weight loss, potentially putting mother and fetus in harm's way. Hyperemesis gravidarum affects up to 3% of all pregnancies. It's a clinical diagnosis that consists of persistent nausea and vomiting with laboratory evidence of malnourishment and a weight loss of at least 5% of mom's pre-pregnancy weight, which we've symbolized with a skinny pregnant lady's greater than 5% belt buckle. Here on our cruise events board, we have a typical schedule for nausea and vomiting. Fun-filled cruise activities. Nausea and vomiting due to pregnancy typically starts prior to 9 weeks gestational age, which is why the first activity is marked to start earlier than 9 a.m. Symptoms that start after 9 weeks gestational age should prompt you to consider other causes of nausea and vomiting, such as cholelithiasis or preeclampsia. For most women, these symptoms resolve by 16 to 20 weeks gestational age, which we'll remind you of with this happy face singing karaoke, which is a fun event set to start at 2000. Unfortunately, a smaller percent of women can experience symptoms throughout their entire pregnancy. In addition to the major discomfort that nausea and vomiting in pregnancy causes, prolonged vomiting can cause maternal and fetal complications related to starvation that may even require multiple inpatient admissions. While the exact etiology of nausea and vomiting in pregnancy, including hyperemesis gravidarum, is unknown, there have been studies that show that certain hormone levels are correlated with the strength and persistence of nausea and vomiting. One hormone that's been linked to nausea and vomiting is our good old friend beta-HCG, represented by these beta glasses on these pregnant women who still can't seem to hold anything down. One reason that beta-HCG has been identified as a key player in the nausea and vomiting spectrum is that pregnancies that have much higher levels of beta-HCG, such as multifetal gestations and molar pregnancies, tend to have higher rates of hyperemesis gravidarum. Also, of all the hormones we're going to review here, only beta-HCG peaks in the first trimester, which is when nausea and vomiting is usually the worst. Another hormone implicated in all of this is estrogen in the form of estradiol, symbolized with our recurring symbol, the estrogen flower. Increased levels of estradiol correlate with increased nausea and vomiting. This is why cigarette smoking is considered protective from hyperemesis gravidarum, because it lowers estradiol levels. Hey, wait, I know what you're thinking. And no, prescribing a pack of cigs to a pregnant woman is not a good idea. The final hormone we'll discuss is another one out of the greatest hits of pregnancy, progesterone, represented by this protective dome. Remember progesterone from our maternal physiology sketch? It makes everything relax, including the esophageal sphincter and the stomach. This causes gastric reflux as well as delayed gastric emptying, both of which can contribute to nausea and vomiting. Now let's go over a patient who's experiencing pretty bad nausea and vomiting. We'll go over how to do the full assessment to either rule in or rule out hyperemesis gravidarum and go over the spectrum of treatment options for nausea and vomiting in pregnancy, from mild symptoms all the way to the most extreme. We're going to represent the typical demographics of patients who are most affected with extreme nausea and vomiting of pregnancy on this lady who looks like she tried to have her baby shower on this boat. Maybe that wasn't the best idea. Just like her, the typical patients with extreme nausea and vomiting during pregnancy you'll see are young women during their first pregnancies. Strangely enough, carrying a female fetus also increases the risk of having hyperemesis. Can you guess what the main symptoms of nausea and vomiting in pregnancy are? I'll give you a minute. In addition to nausea and vomiting, things start getting serious when a patient can't hold down any oral intake, which we've represented with this no food on deck sign. When taking a patient's past medical history, there are a few risk factors to ask about. Patients with a history of hyperemesis gravidarum in a prior pregnancy, a history of migraines, and those who get motion sickness are more likely to have hyperemesis gravidarum in their current pregnancies. Looks like this lady has all three. A history of hyperemesis gravidarum in family members, especially if a patient's sister or mother had it, also increases the risk of developing this condition. Now let's move on to the patient's exam and typical lab findings. When taking her vitals, look for any signs of dehydration. If the patient is severely dehydrated, her vitals will show orthostatic hypotension and tachycardia, represented by this man diving down into the pool with his fancy heart watch on a raised arm. Also, remember to weigh the patient when you assess her. If she's lost greater than 5% of her pre-pregnancy weight, she may fit the clinical diagnosis of hyperemesis gravidarum. Overall, the physical exam will also reflect dehydration. If she's volume depleted, you'll see dry mucous membranes, which can manifest as dry or cracked lips and pale dry oral mucosa. In terms of labs, if she's severely dehydrated or nutritionally deficient, the values you'll see reflect either volume depletion or evidence of starvation. A CBC will show hemoconcentration secondary to volume depletion, which we've represented by this cluster of red beach balls in this low-volume pool. If you were to get an ABG, it's possible to see a hypochloremic metabolic alkalosis, represented by the sinking chlorine buoy releasing an OH bubble. Another consequence of activating the RAS system is that potassium is also secreted, so you can see hypokalemia on labs. Continuing the trend of low values, calcium and magnesium will be low due to poor nutrition. However, there are some elevated values that can be seen in these patients. In up to 50% of patients with severe vomiting, you can see elevated transaminases, with ALT usually higher than AST. However, both of these values will usually not exceed 300 units per liter, so they should be nowhere near the range for hepatitis. Amylase and lipase, represented by these hanging bitten apples and fatty potato chips, respectively, can also be markedly elevated, up to 5 times more than their normal values. But again, they're nowhere near as elevated as the values seen with pancreatitis. Finally, a urinalysis is going to give you one of the biggest clues as to whether or not this patient is in starvation mode. If a patient has ketonuria, represented by these candy key snacks, our recurring symbol for ketones, in a puddle of yellow liquid, she has undergone starvation ketosis. Dehydration will also manifest as an increased urine-specific gravity on UA. While laboratory testing is the mainstay of evaluation, if the patient hasn't had an OB ultrasound and is early in her pregnancy, make sure to get one to see if she has evidence of a multifetal gestation, represented by these twin dolphins, or a molar pregnancy. On ultrasound, a molar pregnancy will show no fetus and a snowstorm pattern that looks like these bubbles the dolphins are blowing. Now on to our DDX. Before you definitively attribute nausea and vomiting to pregnancy, it's imperative that you rule out other causes. Symptoms that are not part of the constellation of typical nausea and vomiting of pregnancy are severe abdominal pain, fever, and a headache. If your patient complains of any of these, make sure to work her up for other causes of nausea and vomiting. For a complete DDX for nausea and vomiting in pregnancy, refer to this DDX menu. Once you're sure that the nausea and vomiting your patient is experiencing is due to pregnancy, it's important to assess how severe her symptoms are as well as her volume and nutrition status, which is done by checking to see if she has any urine ketones due to starvation. If you're concerned for hyperemesis gravidarum, look at your physical exam and labs to see if she meets the criteria for diagnosis. Again, their persistent nausea and vomiting, a weight loss of at least 5% of her pre-pregnancy weight, and evidence of malnutrition on labs. Patients who fail outpatient treatment, cannot tolerate oral intake after a round of antiemetics in the ED, or anyone who shows lab abnormalities, such as metabolic alkalosis, should be managed in the hospital as an inpatient. Now let's talk about treatment, which is going to be symbolized over here at the Treat Yourself Spa. The best treatment for nausea and vomiting in pregnancy is prevention, as the earlier the symptoms are controlled, the better controlled they are overall. Prevention and early treatment can prevent hospitalization for severe nausea and vomiting down the line. Women who take prenatal vitamins for 1 month prior to pregnancy have been shown to have less nausea and vomiting than women who have not. For women who have mild symptoms, usually more nausea than vomiting, the first interventions are lifestyle and diet changes. In terms of lifestyle changes, counsel your patient to avoid any triggers that bring on her symptoms. These are usually certain odors, noises, or certain temperatures. Diet changes encompass changing the amount and timing of eating. Instead of eating 3 big meals a day, counsel her to try small but frequent meals. Also, meals that are higher in protein are thought to help alleviate nausea as well. If the patient's nausea and vomiting persist despite these changes, then it's time to move on to pharmacological treatment. First-line medications include pyridoxine, also known as vitamin B6, plus or minus the antihistamine doxylamine. Pyridoxine, represented by these pair of ducks, get it? Pyridox. Ducks? Has been shown to improve nausea. Usually, it's started as a single agent, but if the nausea persists, then doxylamine is added. Thankfully, there are many formulations that combine both of these medications into one pill so that it's convenient for the patient. If the combination of pyridoxine and doxylamine doesn't work, you can try substituting out doxylamine for another antihistamine, such as diphenhydramine. If swapping antihistamines still doesn't control her symptoms, it's time to bust out the big guns. Overall, these drugs are safe in pregnancy, but using some of these medications in combination with one another can cause dangerous side effects. Also, all of these drugs can be administered via parenteral routes, either IV, IM, or via suppositories, which is especially helpful if your patient can't tolerate oral intake. Dopamine antagonists, symbolized with our recurring symbol, a rope, are the next in line after antihistamines. There are many classes of dopamine antagonists, but the ones that are used most often for nausea and vomiting in pregnancy are metoclopramide or one of the phenothiazines, either promethazine or prochlorperazine. These medications can be used in the first trimester, as studies have shown that they don't increase the risk for congenital malformations. However, keep an eye out for one of the major side effects of dopamine antagonists, tardive dyskinesia. If the patient starts having abnormal repetitive facial movements that they can't control, it's time to stop this medication. If adding a dopamine antagonist doesn't relieve symptoms, it's time to add a 5-HT3 receptor antagonist, most commonly ondansetron. You probably remember the symbol for this from Sketchy Farm, the ribbon dancer. While ondansetron has few maternal side effects, some studies have shown that it may slightly increase the risk of congenital cardiac and cleft palate abnormalities. For this reason, unless there's no other option, you should try to avoid administering ondansetron prior to 10 weeks gestational age, which is why this time her ribbon is flowing in the shape of a 10. If that patient is refractory to all the aforementioned treatments, you can try corticosteroids such as methylprednisolone. However, these should also be avoided before 10 weeks gestational age because of a small association with cleft palate abnormalities. Now that we've covered the interventions that can help treat symptoms, let's address what should be done when your patient can't tolerate PO intake and starts losing weight. IV fluid should be given to patients who cannot tolerate oral intake for a prolonged period of time or if they show signs of dehydration, such as dizziness or feeling lightheaded. In patients who show signs of nutritional deficiency, further supplementation may be added to their IV fluids, such as dextrose, thiamine, or other electrolytes. If the patient is losing weight and can't tolerate oral intake, then enteral feeding through a nasogastric tube should be started until they're able to take in nutrition by mouth. Total parenteral nutrition, or TPN, should only be given if the patient still has vomiting when being fed through an NG tube. The reason for this is that there's a high morbidity associated with TPN, such as infection, pain with the PICC line, and line failure. If not treated adequately, prolonged vomiting can cause serious complications that affect almost every organ system. We'll review some of the more commonly seen and severe complications here on this water slide. Malnutrition can cause poor wound healing and immunosuppression. It can also cause thiamine, aka vitamin B1, deficiency, which can cause Wernicke encephalopathy, a neurological disorder that presents with encephalopathy, gait ataxia, and oculomotor dysfunction. This is one of the most serious complications of hyperemesis gravidarum. If left untreated, Wernicke encephalopathy can lead to permanent neurological damage and even maternal death. Dehydration can cause acute kidney injury and acute tubular necrosis. Repetitive vomiting can cause tears in the esophagus, also known as Mallory-Weiss tears. These can cause bleeding, and the patient may complain of seeing blood in their sputum. A much more serious complication along the spectrum is esophageal rupture due to the force of vomiting, also called Boerhaave syndrome, which can occur if vomiting is forceful and frequent enough. This one is a surgical emergency. Other complications that can be seen due to the stress of repetitive vomiting are pneumothorax, diaphragmatic tears, and splenic avulsion. While the list for maternal complications is long, thankfully the list for fetal complications is much shorter. Mild nausea and vomiting hasn't been shown to have any measurable effects on the fetus. However, hyperemesis that causes malnutrition can be a cause of growth restriction and eventual low birth weight in the fetus. In terms of preventative measures, if a patient has a history of hyperemesis gravidarum in a previous pregnancy, you can discuss starting anti-nausea and antiemetic medications prior to the onset of symptoms. Okay, let's try to wrap this up so this ship can dock and these ladies can get home and puke in privacy. The nausea and vomiting spectrum of pregnancy ranges from mild symptoms to an extreme condition called hyperemesis gravidarum, which is diagnosed with a loss of greater than 5% of a woman's pre-pregnancy weight and lab evidence of starvation. Typically, symptoms start before 9 weeks gestational age and end by 20 weeks gestational age. The hormones associated with nausea and vomiting during pregnancy are beta-HCG, which can be super elevated in multifetal and molar pregnancies, as well as estrogen and progesterone. The typical patient is young and in her first pregnancy. She'll complain of nausea, vomiting, and maybe PO intolerance too. Risk factors include a history of hyperemesis in a previous pregnancy, migraines, motion sickness, and a family history of hyperemesis gravidarum. Among the most important lab findings you may see are hypochloremic metabolic alkalosis and ketonuria. If a patient has had nausea and vomiting during a pregnancy in the past, she should take prenatal vitamins for at least a month before conceiving. Conservative treatments consist of lifestyle modification with small, frequent, high-protein meals every 1 to 2 hours and avoiding triggers such as odors, noise, and heat. First-line pharmacologic treatment is pyridoxine plus or minus doxylamine. If that doesn't work, then you can try giving her dopamine antagonists, such as metoclopramide, 5-HT3 receptor antagonists, such as ondansetron, or corticosteroids, in that order. Always make sure to also keep an eye on her nutrition. Start with IV fluids. If she's losing weight and can't keep food down, she should be fed through an NG tube. The last resort is TPN because it has such a high rate of complications associated with it. Finally, we went over complications of prolonged nausea and vomiting in moms, which includes malnutrition that leads to poor wound healing, immunosuppression, and Wernicke encephalopathy, a potentially fatal complication due to thiamine deficiency. Other complications include Mallory-Weiss tears, esophageal rupture, and kidney injury. And on that note, our cruise has come to an end. We hope the seas are a bit calmer next time we try to take a cruise, especially for that poor lady who was trying to have a party on board. So until next time, bon voyage!